it's not really an issue. There we go. Okay, so I think the plan a bit more for this term is we're still trying to keep it along the module by module thing, so you don't have to turn up to loads of stuff. You turn up once every 3 weeks and you learn something fun about the module you're on. But we're gonna go back to mixing it up a bit in terms of cases, because a few people asked for that. It's a bit more it's a bit more digestible than just telling you about something, and it's a bit different compared to what the med school usually does. So yeah, as usual, if you don't like it, just let us know in the feedback, and we'll take it on board, of course. So yeah, I've got a couple of cases. Jake's got a couple of cases. All of this stuff I would say is pretty examinable stuff. Not too much niche stuff in this one. So we'll start off with an SBA. I haven't had time to set up Menti because we've just got out of this online exam presentation. I'm sorry, but yeah, just in front of you on a piece of paper, write down an answer and commit to an answer, because if you get it wrong, you're more likely to remember it. So you can have a minute to have a go at this. Yeah, and if anyone has any questions, yeah, just put them in the chat as we go along. We'll get to them, or you can turn your mic on at any point. Yeah, it's chill. Do what you want, basically. Okay, so, well, some people are still thinking, does anyone want to tell me what the likely diagnosis is? So the main features are a 7-day fever, cervical lymphadenopathy with these two signs. Actually, before you tell me what the diagnosis is, what's the sign on the top? This is something you might not see in real life, if I'm honest, but unless you're at Luton, you're quite unlikely to see this disease, but it's quite a big exam topic. Or the sign on the bottom. So what are either of these signs? Yeah, so strawberry tongue is the sign on the bottom, and because it kind of looks like the skin of strawberry, it's red. You've got spots on it as well. And then the one on the top is desquamation of the skin. And if you put those together with the long history of fever and the lymphadenopathy, what kind of disease process are we thinking of? What was the diagnosis? Yeah, this is Kawasaki disease. So we'll talk about why this is the answer, but so the most important investigation to order in Kawasaki disease is an echocardiogram, and we'll get on to why that is in a second. So Kawasaki disease is an inflammatory vasculitis that's predominantly seen in children. It's basically not seen in anyone that's not children. And there's a really good mnemonic to remember the features of Kawasaki disease. Does anyone know the mnemonic? I won't ask you to name each of the bits of the mnemonic, but the mnemonic itself is quite good. It's 2 words, and it's 2 things you don't want to do when driving a car, generally. Okay, maybe that was a bad description based on Jake just giving me the weirdest look. He's like, what? Yeah, crash and burn. You don't want to crash. I mean, generally in life, you don't want to crash and burn. But yeah, so crash is an acronym for conjunctivitis. So they have bilateral injection, red eyes. They get it's like a maculopapular rash, no vesicles anywhere, can occur anywhere on the body. They have lymphadenopathy. It's usually one side in the neck. The strawberry tongue that we just saw And hand is kind of annoying to remember, but like what that's referring to is like the desquamation of skin on the hands or the feet. And burn refers to a history of fever that is 5 days or longer. And often they might also mention that it's unresponsive to paracetamol. It might be unresponsive to NSAIDs. So those are the things you're looking out for in the history. If you saw this presentation with a different onset of with the same symptoms, but like a different like duration, like the fever coming and then the fever occurring and then the rash coming on later, do you know what diagnosis you might think of? That's quite so it looks quite similar, but the fever is much earlier and stops much quicker. That was terrible grammar, I apologize, but you know what I mean. Do you know what diagnosis you might think of? That's kind of, yeah, so you're thinking of scarlet fever. We will talk about like the other like rash related infections another day, because there's like 6 of them and they're all kind of really similar, and I think the best way of learning them all is probably just doing SVAs and knowing like which ones to pick up. I don't know, Jake, what do you how did you learn those?
I think we'll do that as one complete presentation and try and make it more fun, I think, because they're literally all the same but a different name.
Yeah.
So like 1-2 things which make it different.
There's like there's a very buzzwordy, there's like 1 or 2 things like they'll put in each of those like vignettes, and it'll be like it point to a specific diagnosis, and we had one of them in our SBA last year, so it's definitely worth doing at some point. So what kind of scan is this and what is it showing? You can answer either of those 2 questions. This is a coronary angiogram, correct? Yeah. You may have seen this in like a if you ever went to like cath lab, they do these in adults. And yeah, these are coronary artery aneurysms, and this is the reason you need to do an echocardiogram in these children, because they're quite likely to have coronary. Like a number of them will go on to develop these aneurysms that can be quite harmful. So Kawasaki disease continued. So complications, the most important thing you need to remember is coronary artery aneurysm. There are some other ones, but like we won't touch on them today. Management. Anyone know how we manage Kawasaki disease? So what's like the most basic thing we do? Yeah, so the most basic thing is give aspirin. So yeah, you give them aspirin, and it's like a high dose of aspirin. I can't remember exactly how much, but I would check the current guidance.
Does anyone know why this is one of the only circumstances when?
I have a slide on it.
I haven't seen the slides. Apologies.
Yes.
Sorry.
It's a good question though. Yeah. That's a great question. Okay. Yeah. So have a look at like the current dosage. I can't remember at the top of my head, but yeah, aspirin's very important. And then so if they've got evidence of like aneurysm formation already, and there's evidence that there's going to be even more aneurysms, and like the kid's like really unwell, do you know what like a specialist might start? What's like a second line therapy? It's a bit random. Well, it's one of those answers that is the answer to a load of random things. Yes, yeah. So IVIG, yeah, IVIG is used a lot. It's like a specialist decision. Yeah. So don't forget to echo these kids. So you see that presentation, you want to do an echocardiogram. Okay, yeah. So as Jake alluded to a few seconds ago, what is the reason that we avoid aspirin in children usually? There is a one-word answer. Yeah, Reye's syndrome is the reason we avoid aspirin in children. So Reye syndrome is like, it's basically encephalopathy with liver toxicity. So the brain kind of swells, stops working, and then they also get liver toxicity. Interestingly, they don't get jaundice generally as a rule. They don't tend to get jaundice, but This is effectively what's going on in the body. It's very rare, but they basically did a study a few years ago, and they noticed that kids after having viral infections, like, were getting Reye syndrome, like a very small proportion of kids. And they basically looked at two groups. They looked at countries where aspirin was commonly used and countries where aspirin wasn't so commonly used. And they realized that the places where they used aspirin in the treatment of like general post-viral infections had higher rates of Reye syndrome. So now we just try not to give kids aspirin at all. And does anyone? We'll talk about aspirin in a minute, but does anyone know what? So what's this? This is a child. I am aware there's a differential diagnosis if this wasn't a child. It's not a trick question. So this is like the classical rash you get over the hands and the feet in Reye syndrome. So if you see this kind of rash, you want to think of Reye syndrome as well. Hand, foot, and mouth disease is a very important thing to think of when you see a rash that's only on the hands and the feet. It tends to be somewhat. So it tends to be somewhat vesicular in nature. So it can look very similar to this, to be fair. But yeah, in the context of this case, I was alluding that this could be Reye syndrome. But so yeah, they're very similar rashes. So yeah, think of that as well. Do you remember what causes hand, foot, and mouth disease? While we're talking about this, we did it like last term at some point. Do you know which virus? That's another thing that comes up a lot in GP. Loads of kids get it. Think about it. We'll come back to it in a minute. The other question is, if you saw like this maculopapular rash. So wait, have any of you done Mod B? You might not have done Mod B, but if you saw a maculopapular rash in predominantly over the hands and the feet in someone who'd recently had like unprotected sexual intercourse, maybe like in the last few months, do you know what other disease could present like this? Not in a child, obviously, in an adult. Because one of the STIs can look quite similar to this as well. Don't worry if you don't know, because like none of you will have done Mod B yet. So if you see this rash in an adult and there's a history of unprotected sexual intercourse, you might want to be considering something like secondary syphilis. And that looks very similar. So like, yeah. So if you just get given an image, there's obviously a differential diagnosis. But in a child who's had a history of a viral infection, yeah, just think about Reye syndrome. So a bit of a weird jump from aspirin, but there is a link, so we'll talk about it in a minute. What are the types of prevention? So this is some public health that they do, like testing in GP. You will have some public health-esque lectures. Does anyone know what there's like 3 types of prevention that you need to know from like a public health perspective? Primary, secondary, tertiary. Absolutely. It's nice and simple. Primary, secondary, tertiary. Okay, so what is primary prevention? If you had to explain it to a layperson, because like if this comes up, like it could potentially be an OSCE station, and they might ask you to explain it. So like, if you're explaining to a layperson, what is primary prevention? So yeah, the aim of primary prevention is to stop someone from getting a disease in the first place. Can you all think of any good examples of primary prevention that we use like in modern medicine? Vaccinations, yeah, very topical. So vaccinations are a great example of primary prevention, especially things like the pneumococcal vaccine, childhood vaccination. The COVID vaccine isn't so much primary prevention because we try and so with a lot of the COVID vaccines, they prevent severe infection. So they might come under secondary or tertiary. So yeah, but vaccinations generally. Statins are like probably like the most commonly used form of primary prevention for cardiovascular disease. Okay. Do we use aspirin for primary prevention of stroke at the moment? Let's see how well you remember your stroke guidelines, because this is something I saw on the ward on Friday. So would you give someone aspirin? No, you don't. You absolutely don't. So you may see, so when you do geriatrics or when you're on GP, you might see these patients who are started on aspirin like 20, 30 years ago, because at the time they used to think, oh yeah, we can give aspirin as primary prevention, and they might still be on their aspirin at the moment. And like generally all of these people, you will take them off their aspirin because aspirin does increase your risk of hemorrhage. And so if there's no added benefit for like preventing cardiovascular disease, which the evidence shows, then there's no point keeping the person on the aspirin either. Good. So that was primary prevention. What's secondary prevention? Again, imagine you're explaining it to someone who's not in like medical circles. How would you explain secondary prevention to a patient? The slides have definitions. They don't have how you would explain them. Sorry. Maybe I'll add them and then I'll change them. This is a bit trickier. I think secondary and tertiary are a bit trickier than the primary. Yeah, so yeah, that's effectively what it is. So secondary prevention is trying to prevent someone's disease getting worse or recurring, so progression of the disease. What are like some common examples of like secondary prevention that we see? Yes, before anyone says statins, yes, statins are also secondary prevention, but like some other examples. Remember, guys, 20 milligrams is the primary prevention dose of aspirin, 80 milligrams for atorvastatin, and then 80 milligrams is like the secondary prevention dose. So like there's two different doses depending whether you're using it for primary or secondary prevention. But yeah, what are some other examples of secondary prevention? DMARD for rheumatoid arthritis. Yes, I love that example. I didn't actually think of that when I was making these slides, but that's a great example. Anything else? Anything more common that you might encounter in GP or like Jerry's? Like yeah, like giving clopidogrel for stroke, that's a really good example. Yeah, giving ACE inhibitors in like diabetes or renal disease in the long term. Yeah, those are good examples. And then tertiary, I'll tell you because it's just a bit strange. But tertiary is like all about improving quality of life, minimizing complications and symptoms. So like you might ask me in a minute, oh, but isn't the line between secondary and tertiary prevention a bit blurred? And I would say yes, I would agree. It's probably a bit blurred. But like if they ask you about these, they're going to ask you mainly about explaining them, or like they'll ask you about the definition. So I wouldn't worry too much about it. But tertiary prevention is especially significant at the moment with coronavirus. Do you know like, so what drugs do we give for tertiary prevention of coronavirus? So we already spoke about how you could argue that like the Pfizer or the Moderna vaccines are like examples of tertiary prevention. Dexamethasone is a great drug for tertiary prevention in ventilated patients. Yeah. What are the 2 drugs that were approved last week? I'm sorry we're talking about COVID, but like it is relevant. Like it is relevant. Yeah. So arthritis drugs, actually, there's very little evidence that like most of these help with recovery or for mortality anymore. So hydroxychloroquine isn't used. Like there's no evidence that it works. Most of remdesivir has very, very limited evidence. I don't think it's used either. But yeah. So tocilizumab, which is like anti-IL-6, and saralimumab are like the ones to know of for COVID. Like you may as well know them because like you'll see them used on the wards. But yeah, dexamethasone is the big one because it's nice and cheap. We can use it for lots of patients. Cool. So yeah, know the types of prevention, know like the definitions. They could come up. It could be like an OSCE station. It could be an SBA. It could be a 1 marker. But like I think this is some of the easier primary like public health stuff they could ask you about. Yeah. Jake, anything to add about public health stuff in GP?
No.
Yeah. In my opinion, the lectures are a bit dull. Like they're a bit poorly paced. So I think like you can probably read about them more. There's like a good one on like medicine and the law, like where they talk about how like homeless people struggle to access healthcare and like the reasons behind that and what we can do about it. But yeah, so the other ones are a bit dry.
Yeah, I was only going to say before, with just going back to Kawasaki's really quickly, is that I'm not sure anyone remembers, but at the start of, I think it was last year when COVID was coming around, all these kids came in with what they described as Kawasaki's disease more and more. I'm not sure what the data's been on that since.
Yeah, it has a new name. I can't remember off the top of my head. Someone can remind us in the chat if you know. It's like pediatric inflammatory syndrome something. I'll check in a minute.
Which is basically Kawasaki's on steroids.
Ironic.
Yeah.
Kawasaki on steroids.
Anyway.
Also, I clearly put my slides in the wrong order, but yeah, these are the things you want to think about for Reye's syndrome. I don't know why I put that in between, but yeah, rash on the palms and feet, vomiting, seizures. Kids might complain of nightmares as well. It's kind of atypical, but like it's recorded. Yeah, fine. Management of Reye syndrome. God, I really botched up the order. Sorry, I made these pretty. I was clearly tired. How would you manage a kid with Reye syndrome? Meanwhile, I'll look up that syndrome. Kawasaki Pediatric something. Oh yeah, it's called like pediatric multi-system inflammatory syndrome. It's yeah, you don't need to know that for exams, guys. I don't think. Right. So management of Reye syndrome is pretty simple. Supportive care. Stop giving them aspirin. And like if they have cerebral edema, you manage cerebral edema, and generally you can use mannitol to manage cerebral edema. So it's not too complicated to remember. I hope you won't see any of this. Fine. I'll hand over to Jake now.
Okay, so just to finish off, we've got a couple of quick cases. This is more GP peds. So hopefully, if you ever end up doing GP, you won't get a child with Reye syndrome. Although that would be interesting. This is more what you get classically. So back when staycations were still legal, so this was a while ago, you're in GP and it's an 8-year-old boy. So their main complaint is they've got a painful left ear, which they're not happy about, crying, really upset, holding on to mum and dad as they come in. As I said, they've been to the Lake District recently. So Anyone want to type in the chat what other questions you'd like to ask the child or the parents? It can be anything, no wrong answers. Okay, so redness, push forward, discharge. Like it, I know exactly where you're going with that. Definitely you want to ask, but what sort of question could you ask them? So discharge, definitely, you ask, have there been any discharge recently? You'll probably look for redness and the ear movement on examination. Anything else you'd like to ask the child, like history-wise? Discharge, yes, definitely discharge. Yeah. Did they go swimming? Did they have trauma, hearing loss? Yeah, these are all great questions. Did they go swimming? Well, the answer to that one is yes. It couldn't get them out. Always in the lake, in the Lake District. I actually never been to the Lake District. I presume there's lakes there. But yes, they went swimming a lot. Trauma is a really good question. You want to know there's been anything that could be causing this, which more suspicious or sinister. So trauma, definitely. Hearing loss is a great one. Ask them, have they got a history of hearing loss or a history of ear-related problems? Could it be something on something else? Definitely. Anyone got anything else? It doesn't have to be related to the ear. Anything else you could ask the parents or ask them? Just general history. This is a case, guys. It's not like just this and that. It can just be general questions you'd like to ask. Just a couple more. Nice. So yeah, fever. Good. Fine. So these are really good questions. So we were asked the questions, and then I think someone's already said what we like to do. We're obviously going to examine it, but the most important thing you need to work out with is this. Hold on, I think I can take control. There you go. Is this inner or outer problem? So really quick anatomy, because it is useful. How we differentiate inner ear and outer ear and middle ear. So the outer ear is basically the pinna, the helix, the tragus, which form out your outer ear part, and then you got the Eustachian tube, which is this, the canal, the auditory canal. Not the Eustachian tube, sorry, just the auditory canal, and you got your eardrum. All of that leads up to what is the middle ear, and the middle ear is made up of those three bones, and the malleus, the incus, and the stapes. And then you've got your inner ear, which is sort of your hearing and proprioception and balance organs, the cochlear, the auditory nerve, and then that helps in the Eustachian tubes down there, which leads to the pharynx. This is how we differentiate the ear. And the pathology we have in the presentation points us to whether this is an inner ear, middle ear, or outer ear problem. So if you have questions we could have asked about, hearing loss is really good, because hearing loss points to whether this is an inner ear problem. If it's in the outer ear, you're not going to get the hearing loss unless there's been significant trauma, but or problem to the eardrum. So you can sort of differentiate the hearing loss. I haven't gone into that a lot today because that's more ENT subject, but we can talk about it another time. So hearing loss is very good. And then discharge is very good because that points to where the discharge is coming from. And I'll go into that in a bit more detail in a second. So does anyone have any idea what possibly could be going on the child before? So just he's got a painful left ear. It's been swimming a lot. There's very little discharge. He's in significant discomfort, no hearing loss, acute onset, and he is not happy bunny. Never happened before. No significant past medical history. No family history. Just a painful left ear. Does anyone have a stab at what they think the underlying diagnosis is before, of course, you go and do your look in the ear yourself, and the throat? Always look in the throat as well. Otitis externa. Good. So simple, right? That is what you think it would be, and that's because it is. So first of all, otolalia. This is what is otolalia, painful ear. And otitis externa is normally referred to as swimmer's ear because you pick it up when you go swimming. So what this happens is you have acute inflammation of the skin in the meatus. This is the part of the outer ear, the stuff here that makes up the outer ear before. So this can be because of many things. If there's trauma, which is very important, if there is wax or moisture, if there are hearing aids, which are there long term, they can obviously, anything that you put in which is not of like just not shouldn't be there, that can pick up infection, become dirty. And commonly these infections can be Pseudomonas, Staph aureus, or just contact dermatitis, just basically when you've got irritants to the ear. But the most common is Pseudomonas. which makes up 70%, swimmer's ear, Staph aureus, but there can also be fungal infections, and aspergillus, but they're all sort of treated the same way. So presentation, minimal discharge. The reason there's not a lot of discharge in otitis externa is because there's just not the glands to produce it. So you're not going to get a lot of discharge. If it is, it'll be very, very thin mucus discharge rather than anything else. It will be very itchy. They'll be really, you might see them pulling on it sometimes. Then that's them, or scratching it or moving it around. And tragal. So they will be really, really not liking holding on to that ear. Don't go pulling the ear across the room in the GP. The child will be enough pain as it is. In some children as well, they'll find it very difficult when you have a look down the ear with otoscopy. When you have a look, you might not be able to put it in because that narrowing of that auditory canal. So sometimes I've seen GPs not really knowing whether this is otitis externa or the other one we'll go into in a minute because they're just not really sure. So sometimes they cover for both, or they cover for otitis externa only, and then ask them to come back if they display any other symptoms we'll go into. Okay, so management. Anyone know what the management is for otitis externa? What is normally given? Yes, sorry, they will give you more info about how to differentiate between the two. This is just a GP. They will obviously give you pictures and the thing. Good. So yes, I got confused by this a lot in last year. Some questions banks say in GP setting you can just give acetic acid and send them on their way. In others, they say that you should be giving topical antibiotics and steroids, even if it's just mild. But how do you manage it? So basically, this is what I say. Treat the infection. So I think if you're saying this is a severe, or you think they're in real pain and you don't want to make sure you're covering missing anything, there's no one's going to tell you off for giving them the standard stuff, which is either just topical antibiotics or an antibiotic steroid combination. This is something that is called Sulfadex, you'll hear about. It's neomycin, which is a gentamicin derivative or part of that family, and dexamethasone. So you give that, and it comes in the box, and it's so commonly prescribed in GP, I can't even tell you. Literally, they have it on the go and just shove it into parents' faces when they come in with their child with any ear problem, unless of course it's something else. But yes, so Sulfadex is what they normally give. If it's fungal and you think they're fungal, they're spores, or you just, it's a bit weird, or they're immunosuppressed, you give them the clotrimazole. I can't remember that. And then if the drum is perforated, which is unlike otitis externa, then we don't use aminoglycosides. We give something else, which we can look up in your local guidelines. If it's spread to the ear, and we'll go with that, you give all antibiotics, so Fluclox first for the first 7 days. And I'll explain what you mean by spread to the ear in a second. So if there's canal debris, we can remove it with microsuction. And if they have analgesia, okay, so we'll give them analgesia. And if it's necrotizing, which we're going to in a minute, we give them Cipro. So, hold on, sorry, this is frozen. Oh, nothing is working for me. Anush.
Is it? It might be your internet. Wait, 1 second. I've taken control. Oh, it's just frozen. Wait, I'll reshare them. It's fine.
Okay.
I was just going to mention. So yeah, like this is management if you're worried about it, basically.
Yeah.
As I think Jake mentioned, I think a lot of cases are quite self-limiting, and you can just manage that. Yeah. So some places say you can use acetic acid. Some places say you can. I think NICE says you can just use like a warm flannel for the pain. So I don't like. I think it's unlikely that they'll ask you about that step in particular, but it's good to have an idea of like some of the more conservative things we can do. Sorry, I'm just finding the slides again.
No worries. So we're just about to go on to about when otitis externa can go wrong. So I think it was on the slides just there, but does anyone know what I mean by that? Otitis externa going wrong, or something you'll be really worried about and want to make sure you don't miss?
Sorry, give me a second. I'm just struggling with slides as usual.
especially in patients in diabetes. Okay, good. So malignant otitis externa, and I'll just wait for the slides to come up so I can give you a proper thing. But basically, it's that Pseudomonas. So Pseudomonas is it's a really nasty, aggressive infection, which is commonly happening in diabetics. And what happens is that the Pseudomonas can take hold and really spread to parts of the ear. And so that's when we give more aggressive antibiotics. Does anyone know what antibiotics we give for Pseudomonas? Yeah, perfect.
Sorry, just give me a sec. It's just being.
No worries. So yeah, so we give Cipro for Pseudomonas, and the reason is that we want to cover. It's me. We want to cover. No worries. We want to cover for the. Perfect. Nice. Are you showing on your screen?
Yeah, I don't know. It just stopped working.
No,
like it should be fine.
Oh wow, you're going for that very quickly. Okay, nice. Okay, you just have to move it along for me. So yeah, go through to the next bit. Nice. So yeah, get past that and then onto the next bit. Like what is about bit.
That's interesting. The slides just stopped working there.
Oh.
How?
Okay, fine. Don't know. Anyway, here we go. So oh no, there we go. So we talked about this. And the next slide. So this is it. So what is it? So we already talked about it. It's when the infection spreads to the soft tissue, so surround the external auditory canal. So before, all the things we were talking about was when it was only limited to part of the ear. Once it starts spreading around the EAC, we roll it because you know where that place is near. It's near your middle ear, in your inner ear, and that's also near and a few other things. So someone mentioned before about ear pointing forward. Does anyone? I think that's more like it's not that common for this, but does anyone want to expand on what they meant by that? About an ear push forward. Yeah, so mastoiditis. So Anush, you want to move on a bit? So yeah. So first of all, it's life-threatening, and these can be quite sinister. So there might be no fever or raised white cell counts. So you really got to look out for it. It's quite difficult to pick up, but you normally have a much lower threshold for picking it up in diabetics. So that's something that you would always look for if they present with any ear pain. So what can it cause? So temporal bone dysfunction. So it's the bone just behind here, because it can spread like a sort of osteomyelitis. It can spread to the temporal bone in your brain. Next slide, please. And then basically got osteomyelitis. Also, all the cranial nerves come out around here. I can't remember exactly where, but it's like in the brain somewhere around the temporal bone. And the ones that you worry about are the auditory, facial, and accessory. And you can get palsies in these nerves, basically because you get osteomyelitis in that skull, and then all that area is inflamed and nasty. The most common cause is Pseudomonas, as we talked about. Good. And most of this is diabetics, immunosuppression, and those are the patients who have a much lower threshold. And investigations you do, it's just a CT as well. The reason you're doing that is because you're looking for all the gunk in the sinus spaces, which could be pointing to an infection spreading further away from the external auditory meatus. Okay, so now moving on to mastoiditis, and the reason I'm keeping it, I wanted to ask before, is because it's something you always look for anyone presenting with a middle ear, an ear infection. So
I think it's just worth pointing out that like often with otitis externa, surgical debridement is needed. And the other thing that's worth mentioning is, we're going over malignant otitis externa, but like you're unlikely to see malignant otitis externa in kids. That's more like an end stage diabetes type thing. But yeah, surgical debridement is actually a bit more common than you might expect. Like my uncle had to have like surgical debridement because he had this. Yeah, it's pretty rough as the disease goes. But yeah, in adults, you're more likely to see the necrotizing variant. Sorry.
No worries. So we've done the middle ear. Now we're doing case 2 in the ear. So now we're doing case 2. So this is a 10-year-old boy or girl. Oh boy. This morning he had a rapid onset acute pain in his left ear. So after the photo, this photo here on Ofsted which shows this sort of eardrum picture. He complains of discharge from the ear, not nice discharge, quite gunky. And he also says that the pain has got slightly better. So again, anyone want to ask any questions to the child or to the parents?
You probably asked them to the child if they were 10, right?
Probably.
Yeah.
Probably. 10, yeah. Probably. Sometimes I don't quite know this. It's a very good skill speaking to children. It's a good skill trying to communicate.
If you haven't done peds yet, take stickers with you. It's like the best thing to do.
Has anyone got any questions? Or are they happy? They know what's going on? Good. So yeah, hearing loss. You want to know about any middle ear problem. What color is the discharge? Very good. So you might, if they have, you can see it there and then, or if there is any blood in it as well, could probably be something else. Hearing loss. So you're again looking for that middle ear pathology. This child, it's quite hard to tell. He is quite sick and he's unable to get a proper idea of how hearing loss, but he has no previous ear pathology and his hearing is normally fine. Okay, so moving on. So we did middle ear, now inner ear, outer ear, and now we're doing middle ear. This is the best one picture I could find for middle ear. Right. So Malcolm in the middle, so middle ear stuff. So with the middle ear, anyone know what that's called when we have middle ear infections?
I would argue it is the single commonest thing you will see in children at GP.
Yes, otitis media. Very good. So children do get otitis media. This is simply middle ear inflammation. So remember that part I put before where all the bones are, malleus, incus, stapes, and then you have the eardrum. So what happens is you have inflammation and infection, and that produces a lot of gunk, and that gunk causes pressure onto the eardrum, and that's what they get that sort of bulging eardrum picture you saw before. And what happens is because the pressure builds up, the pain is very severe, and then you get the discharge once the eardrum has burst. And commonly, once the eardrum has burst and that pressure is relieved, the patient actually says the pain gets better because of obviously the cause of the pain is taken away. But it's very important to check. It's very difficult to check. If you don't get that picture on otoscopy, it just doesn't happen. You have to. The ear is very hard. But if you can sort of get a picture of the eardrum and see what if it's bulging at all, or if there's a very clear sheen to it, that gives you an idea that there's middle ear pathology. Especially if there's discharge. Discharge is a thing that points you more towards otitis media. The reason that this happens in children is because the tissue is being more horizontal. So that means infections are more easily able to travel up to the middle ear. They normally happen after like a sinusitis infection, or that's normally viral, but sometimes the risk factors are, we'll go into explain here. Thanks, Anush. Any upper respiratory tract infection, they sort of send up to the ear. Bottle feeding, picking up things there and then traveling up to the ear, and then malformation. So cleft palate, you sort of, because of the change in the anatomy, you sort of more it's more easy for infection to travel up to the middle ear. It's just one of those things. And we're not going to talk a lot about cleft palates right now because I'll take away from this. I know we've been going a bit, so I just want to focus on this one here. So the presentation of these children is as I described before, really. So normally, if you load that, please, Anush. So normally there's a rapid onset of pain. So this is acute, as I said, because of the bulge in the tympanic membrane. No discharge until it bursts and then relieved. The child may tug on the outside of the ear. This is more classically for otitis media, but not always the case. They've got very ill, quite toxic fever severity. They're not eating, they could be vomiting, and there is conductive hearing loss. So conductive sensory neural hearing loss. Conductive is based on basically getting from the sound from the outer part of from your environment to your nerve. If there's anything blocking that, like wax or build-up of gunk in the middle ear or outer ear, that's going to stop it getting to nerve. It's going to be conductive. Sensory neural hearing loss is when you've got problems in the nerves. There's things that damage the middle ear. Sorry, the inner ear. So the cochlear and all the vestibular nerve system. That's what's going to give you the sensory neural hearing loss. So here, because you're going to damage the eardrum, which is conducting the sounds in, you get conductive hearing loss. That's what otitis media tends to cause. And we'll go over in ENT another time about sensory hearing loss. You tend to get more conductive in children because of the likelihood of otitis media.
You guys did ENT last year, right? Sorry, I can't see the chat, but yeah, I think so. Like, yeah, I'd recommend going over it for like.
ENT the year before because we did it last year.
Yeah, I still think it's fully worth going over the otitis stuff because it comes up in GP so much.
Yeah, that's mad. I thought they did this year. Okay, cool. Anyway, this is more Peds related, so it's good. So, good. Go on.
I was going to ask a couple of questions actually. So, with regard to otitis media, if a child comes in with recurrent bacterial otitis media, what are you going to be worried about if a child comes in with it? Wait, I need to open the chat on my phone so I can see it.
No, I got it.
It's just something worth thinking about from a pediatric perspective. It might not just be otitis media. They might have recurrent chest infection. Yeah, so glue ear is what you want to think of. That's like a chronic otitis media where they have fluid in the middle ear all the time. Well, if they have recurrent episodes of acute otitis media. Glue ear is something good. We're not going to touch. I don't think we're touching on it today, but yeah, have a read about glue ear. It's quite important. I don't think it comes up that much, but it's quite common in kids. I think I had glue ear when I was younger. So recurrent bacterial otitis media and potentially recurrent bacterial throat and lung infections. What are you worried about? There's a few things you might be worried about. It's like a bit of overlap with year 4, but it's quite important for peds. So it's recurrent lung infections. You're thinking cystic fibrosis, definitely, if it's recurrent bacterial lung infections, because there's a failure to clear this mucus. So very good. Not so much with ear infections. Not as much, but yeah, if it was just lung infections, should someone with a healthy immune system be getting recurrent bacterial infections? Is the question. No, yeah. So what kind of things are you worried about in kids that could be dampening down their immune system in this way to make them more likely to have a bacterial infection? So there's one like red flag diagnosis, and there is one less red flag diagnosis, but is not that it's not that important for exam. So yeah, hematological malignancy is so like an acute leukemia. So in young children, ALL is the one you want to think about. That's causing them to be more susceptible to infections. So remember, if you're suspecting ALL in a child, you need to do a 48-hour full blood count. So a very, very urgent full blood count. The other important thing is Claudia just said is hypogammaglobulinemias or like other immunodeficiencies, but immunodeficiencies aren't like a huge topic, so I wouldn't worry about them. But yeah, remember that you want to think about leukemia if someone's getting recurrent bacterial infections. The other question I was going to ask is if you're getting recurrent otitis media as an adult, what are you worried about? This is another red flag thing that you may have covered last year. So we've done the pediatric manifestation. What's like the adult manifestation? Yeah, so you're worried, could it be like a nasopharyngeal carcinoma, especially if it's just one side and it's constantly getting like an acute otitis media? You're worried. That's another red flag thing. Sorry, just a bit of
no. It's also glue ear, which we won't go into a lot, but also glue ear also is common in adults. You don't normally get it in adults. So adults presenting with glue ear symptoms, which is basically just pressure behind the eardrums, just sort of like not inflammation, just gunk behind the eardrum. Because of blocking off of the Eustachian tube before, so nothing can get away. That's also a sign for possibly nasopharyngeal carcinoma.
Yeah, so that's really good. I'd forgotten about that.
No worries. So we got the presentation. We now need to manage this patient. So with otitis externa, we threw antibiotics, steroids. What about otitis media? How do you manage otitis media? With the kitchen sink or something else? So with otitis media, what's the main thing you want the child are you concerned about? So this child he's got discharge. You can't really look at the eardrum well, but you have a presumption that it's possibly burst because of the reduction in pain. So management of otitis media actually is a bit more conservative than otitis externa. With otitis media, you sort of manage their pain. So you just go up the pain ladder, really. So if you shut this, so the first treatment is just paracetamol. You give these patients, you try and control their pain. You don't give them you give them paracetamol mostly, and you only give the antibiotics if they're getting continuous recurrences of otitis media. You definitely don't want to give any aminoglycosides if they got a burst eardrum because it's ototoxic, and if a burst eardrum, it's a big no-no. So the first line you give is amoxicillin. Thanks, Anush. And then after that, if you load up the next part, then you can also give comoxiclab on top of that if it's not helping, and if they're pan-allergic, erythromycin.
Can I just mention one thing? So generally, aminoglycosides not so useful in otitis media because you can't use them if it's perforated because they're ototoxic, and you can't use them if it's not perforated because it's not going to get in because you have to give them topically. So yeah, just never aminoglycosides. The big difference in management is don't use aminoglycosides in otitis media. You're going with penicillin-based antibiotics.
Exactly. With sometimes you can want to get rid of the debris. You can use oral toilet, which I actually have no idea what that is. It's in my notes. But I think it's just a way of just removing all the debris from the middle ear. You have to look it up in your spare time. But
I think generally you can also only use that if they're perforated. I think
it's just a bit of extra. It's not the thing that people catch out on in otitis media is that first line is just analgesia. So that's what the question for GP is going to be. It's going to be, you think it's otitis media, you've got a pretty clear idea. That might even tell you it's otitis media. You're going to give first line treatment is analgesia, and only if it's really recurrent. I'm not entirely sure what the exact guidelines are. You're very welcome to look them up in your spare time. But if it's persistent, you give antibiotics. And then you give grommets. Sorry, go on, Nish.
Yeah, I was like, I don't think this is very well guidelined. I think this is one of those things that it's really your impression in GP. It's something that they're very unlikely to ask about because there isn't this isn't something you get from a textbook. It's kind of just a vibe. It's like, oh, does this patient really need antibiotics? A lot of what I did this year was like, oh, does this kid need antibiotics?
Yeah, exactly.
There's no correct answer.
So once we've done that, we also got a bit worried about other complications that could become of otitis media. So we already mentioned before about the possibility of the ear pushing forward. So that's more mastoiditis. And I think we can go on to that. So this is it. So it's the inflammation of the mastoid process. So if you see the picture here, I'm sorry it hasn't come out that well, but you can see that there's a bulge behind the ear where your mastoid is, and the ear is sort of, the pin is pointing forward sort of laterally and inferiorly, and there's discharge commonly coming from the inner ear, from your eardrum out here from a burst eardrum from there. This is really, 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 really crucial. Mastoiditis can lead to meningitis, facial palsy, and intracranial abscesses, and also this is what causes sensory neural hearing loss because of toxins affecting that middle ear part, and sorry, that inner ear coming through. So it's really, really important to look out for. It's a classic complication, and very commonly tested. Image this with CT to confirm the mastoiditis, and then you give IV antibiotics, brought back, get it in there. It's really important. That's pretty much the main complication, is mastoiditis. Also, really quickly, we haven't gone over it. I haven't included it here, but I think a very commonly a passment of it is that wax in the upper sort of here superior when you look in the ear and there's discharge. Does anyone know what we're looking for there? Sorry, a bit of a curveball.
I'm just going to stop sharing my screen because that's okay. It's like like terrible discharge in the attic of the air drum. It's like, yeah, you might have covered it last year, but yeah, again, this is quite ear stuff is quite relevant to GP. Oh, by the way, guys, like, go over your 2-week weights for GP.
So exactly. So cholesteatoma. So a cholesteatoma is basically an epithelium malignancy in the upper aortic canal, and it can be described as otitis media because it causes discharge. Something that I don't put, but it's vague. So that is something you always want to look for, and it's a malignancy, so it needs to be escalated to ENT. But that isn't going to be found in kids. So the two main things that kids come for is going to be swimmer's ear otitis media, swimmer's ear otitis externa, and that's you treat with steroids, antibiotics, pain relief, and then look out for any signs that they got immunosuppression or diabetes, and that's more adulty. And then middle ear otitis media, first line is analgesia. They tend to have more discharge and toxic symptoms, and the main complication is mastoiditis. You've got local guideline, broad spec. It's a wild day.
I wouldn't worry about mastoiditis because it's really severe. Like, I'd recommend like use something like piperacillin tazobactam. Like, it's really bad.
The complications for mastoiditis are profound. Like, it's such an amazing pathway for the infection. It can spread to the brain, to the middle ear, to the inner ear, causing hearing loss and the meningitis and facial palsy. It's something that is very quickly escalated, but is commonly examined because it's something that you shouldn't be missing. But you won't miss it because you're gonna smash it. Has anyone got any more questions about GP Peds ear stuff? Which is the majority of what Peds come in for. And also Anush really nicely put in about all the hematological malignancies. That's also a common thing that kids turn up for, recurrent presentations of ill health, little things like flu and chesty cough, ear problems, and commonly these are things how they start presenting with the hematological malignancies. But again, we'll do that another time. But that is another